and President Wilfred and Minaj and all the respected members for
Just to interrupt, I request all others who are not there speaking, please mute your.
You can mute everyone otherwise.
Okay. So I'm Dr. Umakant. Today I'm going to talk about early detection and prevention of cancer. To remind you, today is World Cancer Day, and this is the time where we have to rededicate ourselves to poor cancer patients for their betterment and their treatment. If you look at the World Cancer, why World Cancer Day has to be done? It was founded on February 4, 2000 during the World Cancer Conference for the New Millennium in Paris. And this year's slogan for the World Cancer Day is Close the Care Gap. Whatever the cancer care being done worldwide, the gap in terms of facilitation, in terms of providing the treatment facilities, in terms of investigative facilities, this particular gap should be fulfilled beyond the boundaries of the country. That is the main aim of the World Cancer Day for this year. This is going to happen next few years. It is not 1 year program. It is going to happen in forthcoming years. So before I start, what are the risk factors for the cancer actually? What are the risk factors? The cancer is an age-old disease right from the ancient history. The cancer being diagnosed, and it was there. The disease ever since mankind is found, the cancer is there as a disease, and it was identified by our ancestors, before Christ, and the treatment options were started before Christ only, and later on the treatment facilities, investigative modalities have been changed and have reached present stage. But still, we are not able to control over the cancer and cancer treatment. So, since the difficulties in the treatment involved and the outcomes involved, we have to identify what are the risk factors which are going to develop cancer in various patients. The risk factors, basically a family history of a cancer becomes a risk factor for the next generation families, and diet they eat, the various kind of diets which are described, the risk factors for the cancer development, and chemicals we use, especially in terms of the pesticides, in terms of fertilizers, in terms of preservation of the food. There's so many chemicals are being used in our regular day-to-day life, and these are also risk factors for the cancer. And the hormones, indigenous hormones, especially estrogens, sometimes progesterones, and some other hormones which stimulate these particular cancer cells in high-risk individuals. And aging itself is a risk factor. As you become more and more aged, the senescent cells are more prone for becoming cancers. And the race, as you know, the various races which are there in the world, particular races are risk for particular cancers, especially Jewish race is more prone to develop breast cancers, and in Asian countries, we are more prone for liver cancers. Like this, based on the race also, there are risk factors. How these risk factors would help? They are help in segregating the groups of the patients or groups of the population which develop particular cancer, and focus on that particular cancer, and investigations are identifying the patients or focus on the treatment. So what are these risk factors which can be modified? It is very important. It is also important to which risk factors can be modified. For example, overweight and obesity is a risk factor that can be modified by exercise, and alcohol abuse can be stopped. Cigarette smoking, which is the most dangerous habit, which is the fundamental cause for the cancer throughout the world. I'm going to discuss in next few slides. And excessive processed food and red meat is also a risk for the cancer. especially colon cancers, and the low fruit and low vegetable diet, where dietary fiber is slowly becoming less and less in intake when compared to our ancestors because of the modern lifestyle. This is also increasing the risk of colonic cancer. So if you increase the intake of fruits and vegetables, naturally the risk of cancer will go down. See, these are all the estimated percentage of cancer caused by identifiable and potentially preventable factors. Very important. They are potentially preventable. If you look at the first, tobacco, it is 33% of the cancers are caused by tobacco. 33%. If you look at the chapter, and excess weight and obesity causes 20% of the cancers. The top two, almost 53% of the cancers are caused by tobacco and excess obesity and weight. And another, if you see the last line, unknown, 11%. This includes genetic and chromosomal abnormalities. So roughly 63% are these three only, and the rest are diet 5%, lack of exercise 5%, occupation 5%, viruses 5%, family history 5%, alcohol 3%, UV and ionizing radiation 2%, and various drugs and reproductive factors and pollution 2%. So if you look at the greatest killer or the greatest cause of the cancer, it is tobacco, and next is lifestyle disease like excessive weight and obesity. It is very important to note that the risk factors are obesity and tobacco, and third one is genetic and familial.
Join audio.
What are the methods to prevent cancer?
Driver ki train ticket
Simple methods to prevent the cancer.
train ticket
Healthy lifestyle.
bus ticket
Sujit, unmute everyone.
I request to mute this thing because it's caused a lot of disturbance to me. What are basically healthy lifestyle, diet, tobacco, stop alcohol, and another three important things is screening, treatment of precancerous lesions, which will prevent these precancerous lesions to become cancerous lesions. Third one is vaccines. There are two important vaccines to remember is hepatitis B vaccine and human papilloma virus vaccine, which I am going to brief in 1 or 2 sentences. And if you look at modifiable risk factors are till alcohol, tobacco. And after that, screening is very important. Screening concentrates on picking up asymptomatic cancer patients and precancerous conditions. These two are very important factors, and it goes a long way to have a good treatment to cancer patients. See, this is the concept of screening. In general population, if you do a screen test for particular cancer, you can identify the patients who are asymptomatic, or they have some precancerous conditions, and later they can be subjected for further test, and they can advise and you can give support them. And this is very important to pick up early stage cancer so that they will have a good prognosis and better survival rates. See, screening can detect a silent cancer with no symptoms in a healthy individual, and early detection in stage 1 and stage 2 cancer and a better treatment options are available, and a better survival rates are described. And detection of a precancerous lesion and treating them would be best way to prevent cancer. So screening carries a very big importance in prevention, early detection and prevention of the cancer. If you treat a precancerous condition, you can prevent a cancer. If you pick up a cancer in an early stage, you can have a better survival rates. What are the cancers that can be screened in general? Breast, oral cavity, cervix, lung, colon. As such, most of the cancers can be screened, but screening investigations are lot of laborious, and they cause some amount of morbidity and discomfort to the patients. So at least you identify the high risk groups and subject them for screening procedures, especially colon and all those things. They require colonoscopy as a screening, so they cause some amount of discomfort. So identify the risk groups and then subject them for colonoscopy and other these kind of invasive procedures. Whereas breast and oral cavity and cervix they have got less morbid procedure, less discomfortable procedure. So subject the general population for the screening programs and in these three particular cancers. So if you look at this slide, you can put a stop for progression of the disease by applying screening test for the general population and high risk groups. See, these are all the common cancerous lesions. I am just trying to show the pictures. The number one is CSR cervix, cervical lesion is a white patch. This is aceto-white. This is called VIA, that is visually identified aceto-white patch. This is either a precancerous lesion or a cancerous. And these one are mammography. This is done for breast, and this is a speculated irregular radio opaque density with microcalcification. This is a sign of malignancy. And here also you can see doubtful calcifications. And this is a oral cavity lesion. This is erythroplakia. This is a precancerous condition. See, I just want to show these three particular cancers where precancerous conditions are described in these three conditions. Here you can see CIN1, CIN2, CIN3 lesions which are precancerous. And to tell you, it will take almost 1 decade for a CIN to become invasive cancer. So you have 10 years long time to pick up and screen these patients and subject them for treatment and prevent cervical cancer. Here, breast cancer is also not very fast growing tumor. Suppose if you identify these patients at the level of atypical hyperplasia and dysplasias, you can still prevent breast cancer to occur, and you can remove that tumor. These are all the common and standard 7 warning signals of the cancer. A change in the bowel or bladder habit, a sore that does not heal anywhere, either in the skin or the oral cavity, an unusual bleeding or discharge, thickening or a lump in the breast or elsewhere, anywhere in the body, and indigestion or difficulty in swallowing, and obvious change in a wart or a mole, and nagging cough, hoarseness which is not subsiding on regular treatment for more than 2 weeks. You have to take it as a warning signals for underlying cancer. It's very, very important. There are simple symptoms which are very surprisingly not noticed and not subjected for investigations. And this is one of the important cause for occurrence of the cancer and missing a cancer diagnosis. See, vaccines and cancer is one very important thing. Hepatitis B vaccine, which nowadays we are included in national immunization program by central government. So it has helped. It has gone a long way to prevent the hepatitis B induced liver cancers. Next generation. And next one is HPV vaccine. This helps in preventing cervical cancer. HPV vaccines are given before age of reproductive age, and this is going to, if it is not used as a large scale as hepatitis B vaccine, but once this particular vaccine is used, it is expected that in the next generation the cervical cancer incidence will go down, as it has seen with the hepatitis B vaccination. So with a simple outlining about the prevention and what are the high risk factors in a simple way to rewind and discuss, I am going to talk about 3 cancers. One is breast cancer, second is oral cavity, third is cervical cancer, regarding screening and early detection. This is what topic is given. See, 1 in 8 women will be diagnosed with breast cancer in their lifetime. That we have to remember. So almost all women, 1 in 8, they are going to develop breast cancer. That much incidence is there in the present society. So all women should be very careful about their health of the breast. Breast health is very important, women, as far as if you look at the cancer incidence is concerned. So what are the symptoms of breast cancer in general? One is a lump in the breast, any pulled up nipple, any dimpling in the skin, any discharge, that is nothing but dribbling from the nipple, any kind of discharge, and any red rash, and any skin changes. So these particular things, whenever they notice, if you suspect cancer, that is going to pick up or exclude or confirm the diagnosis. These particular symptoms are, unless proved otherwise, they are cancer symptoms. And what are the risk factors in a woman? See, the risk is divided into more than 4, 2 to 4, and 1 to 2, and other risk factors. If you compare to the male patient, female patients are more prone to develop breast cancer. And second is age more than 65 years, although there is an increased risk across all ages until the age of 80 years. And nowadays we can see the cancers in younger age group, they have the genetic background of BRCA1 and BRCA2 gene positivity. That is certain inherited genetic mutations in breast cancer, that is BRCA1 and BRCA2. 2 or more first degree relatives with breast cancer diagnosed at an early age. below 50 years is also a risk factor for next generation. And personal history of a breast cancer on the one right-sided breast, the other breast will become more risk for develop breast cancer. And the high breast density is also a risk factor for the breast cancer. And a biopsy confirmed atypical hyperplasia in a given patient, they make that patient high risk for the breast cancer. And the risk between 2 and 4 is 1 first degree, whereas if there are 2 first degree relatives, the risk will be more. If there is a 1 first degree relative, the risk will be little less. And once again, a patient has taken high dose radiation for some other disease, then high bone density, these two are also having the risk for breast cancer. And the factors that affect circulating hormones, like late age at first full-term pregnancy, early menarche, late menopause, no full-term pregnancies, that is nulliparous, and never breastfed a child. These are all and any recent use of oral contraceptive use, recent and long-term use of hormone replacement therapy, obesity, all these things also once again risk for breast cancers. See, other factors like personal history of endometrial and other cancers, ovary cancer, colonic cancer, that makes someone more risk for breast cancer also. And any alcohol consumption, especially alcohol consumption among the women, has increased the incidence of third world countries, the breast cancer. And other like high socioeconomic status and Jewish heritage, as I told, the particular race has got more risk for breast cancer, especially BRCA1, BRCA2 based. So how to pick up this breast cancer early? It is a very simplest method and time tested is breast self-examination. You can ask the patient or whoever comes to your consultation, ask the patient to, after menstrual period, she can pick up one particular day in every month and examine her entire breast in front of a mirror and look for any small nodules or any changes, obvious changes she can see. And later she can palpate breast in all 4 quadrants and axilla as well as below the nipple. These 5 areas, if they examine with their finger, they are likely to pick up any change in the consistency or any lump they can pick up. Once you should advise the patient, once you pick up any abnormality, you should go and meet clinician so that they should get examined by clinician. So there are 2 components, self-breast examination and examination by clinician. Always examination clinician is superior, but they can't go for examination every month. They can do it in their house. And whenever they have a doubt, they can attend a clinician for confirmation or further investigations. This goes a long way to pick up early breast cancer. See, this is the slide says an untrained patient sometimes may not pick up a bigger lump, whereas a trained clinician can pick up a smaller lump. So a clinician's hand is better than a routine patient's hand. See, this is the thing I want to show, examination by clinician. And once this is for any clinician who come across any abnormality in the breast, they should always advise the patient for triple assessment. One is clinical examination by a qualified person, and second is radiological assessment either by ultrasonogram or mammography or MRI. In a very young patients, first we have to do an ultrasound, and mammography is advised when the patient is more than 49 years or a definite suspicion of malignancy. You can submit. And MRI is advised when patient comes with a high risk family group with BRCA1, BRCA2, and patient is very young, below 17, 18 years, and then those patient requires any follow-up, you can do a MRI program. And the third and most important thing is any lump in the breast or any discharge from the nipple should be subjected for pathological assessment. That is by doing true cut biopsy. True cut biopsy, sometimes it is not available in rural areas. Then they can, if it is possible, you can do a FNAC also. Instead of, if patient doesn't come for city or urban areas for true cut biopsy, at least you can get it in a FNAC. But true cut biopsy gives the accurate diagnosis, and that is the gold standard for biopsy. But still in our country where the facilities are not there in the rural area, still FNAC can be practiced. That will give you some clue regarding the diagnosis. So you don't forget, always you should do a triple assessment: clinical examination, radiological assessment, and pathological assessment. This gives either confirm or excludes the malignancy. See, another very important thing is mammography in the breast. Mammography is used as a diagnostic as well as screening tool. Screening is for general population or in high risk individuals or high risk groups. And second is as a diagnostic purpose, if patient
4th February Cancer Day है.
if patient comes with a breast lump, then you can subject the patient for a mammography and assess that particular lump and find out any suspicious findings like microscopic calcification or speckled irregular margins, these kind of things, and then subject the patient for other investigations. This is a mammography machine. You can see a mammography is taken in different oblique directions by compressing the breast. That is a machine actually where you should compress the breast and take this. We have to inform to the patient so that they will be well aware of how the procedure is done. And for whom you should advise mammography. Mammography is in our state. Recently, today itself, we have started a mobile mammography bus actually for the rural population. Today only we have started in MNJ Cancer Hospital by Honorable Health Minister Harish Rao, who came and started that. And whom you should do mammograph actually. Mammograph should be done in all women who are 49 years according to the American consensus, and they should be done annually. And second thing is, from 50 to 74 years, every 1 to 2 years you have to do. It is recommended so that we can pick up suspicious or an early cancer lesions. If you look at the effectiveness of the screening, 68 to 90% sensitivity in women more than 50 years, and 62 to 76% sensitivity in women more than 40 to 49 years. Specificity estimated between 82 to 97%. So this tells that mammography is a very useful screening tool to pick up malignancy or suspicious lesions in women. So mammography nowadays is become more popular to screen the breast, and the government is also providing these particular mobile mammography vans to screen our rural population. These are all the various mammography findings. One is normal mammogram, second one is benign cyst, third one is a cancerous lesion with us. You can see speckled and irregular radio opaque density, and you can see here the speculated calcifications, which is abnormal, and is a sign of malignancy. So in very early stage malignancy also you can pick up with a radiograph or mammograph by looking at the small microscopic calcifications. These are all the abnormalities of mammograph. These two red marks are malignant lesions. This is a very small lesion, which this was not palpable, but this lesion was palpable. These are also malignant lesions. So now if you look at this particular chart, I picked it up only to say that suppose if you pick up a patient with a mammography where only atypical hyperplasia has come as an abnormality, then they will have 100% survival rate. Otherwise, if you miss this will enter into stage 1. If you pick up the patient at the stage 1, the survival is 98%. Still it is good. And if you pick up the patient at stage 2, then the survival is 88%. And then if you pick up the patient at stage 3, then survival is 52%. And if you pick up the patient at stage 4, then survival is 16%. So that is the importance of picking up the patient at precancerous condition. Patient will have 100% survival rate. This is the small treatment chart. You can give chemotherapy as a neoadjuvant or adjuvant, and followed by surgery, followed by radiotherapy, hormonal therapy, or plus or minus chemotherapy based on the stage of the cancer. See, I'm trying to confine myself for only screening and early detection. The next important cancer is cervical cancer. Once again, women population is affected, and especially it is more common among the rural flocks. Very unfortunate. They always neglect these symptoms, both by the patient as well as attending clinicians. Say most of the patients, they will attend the quacks in the villages. So they all miss this particular symptoms as they're treated with the antibiotics and whatever without subjecting them for screening programs. And patients are coming to our hospital with an advanced stage where we are not able to provide proper treatment. So what is the risk factors? Once again, human papilloma virus 6, 11, 16, 18 subtypes are infection with these particular virus is a risk for cervical cancer. And unhealthy sexual habits, multiple sexual partners, and neglected vaginal infections, all these things are, they increase the risk for cervical cancer. And precancerous lesion to invasive cancer, as I told, it will take 1 decade. So you have 1 decade time to screen them and treat them. And average age is 49 years, but no age is exempt. You can still diagnose the cases from 20 to 65 years. It is generally less common after 65 years. These are all the 10 warning signals of the cervical cancer. One is unusual vaginal discharge, abnormal vaginal bleeding, heavier and longer menstrual cycle, discomfort while urinating, loss of bladder control, pain during intercourse, constant fatigue, pelvic pain, and unexplained weight loss and leg pain. These are all the warning signals of cervical cancer. Any patient comes with these particular symptoms, those patients are subjected for screening for the cervical cancer protocol. What are the methods of screening for cervical cancer? Number 1 is pap smear. Any warning, any symptom which directs you towards cervical cancer suspicion, you have to subject the patient for pap smear. And then visual inspection methods. You have to take a pap smear and also examine visually by after applying acetic acid on the cervical region. And third one is HPV testing. Any pap smear, any doubtful histopathy, any doubtful cytology on the pap smear, you have to subject for HPV testing, which HPV testing may not be available regularly on the rural center, but still wherever possible, it is better to get an HPV testing on the slides. And these are the guidelines for the cervical cancer. The screening guidelines: less than 21 years, no screening is recommended. 21 to 21 years, the pap smear every 3 years it is recommended. And any abnormal test should be followed up by HPV testing as well as visual inspection. And 30 to 65 years, cytology and HPV testing every 5 years. This, any abnormality in the cytology, then comes visual examination and HPV testing. And more than 65 years, generally, there is no previous cervical pathology, then screening is not necessary. But if there is a previous cervical pathology, then screening has to be continued even after 65 years. If you look at this pap smear, this thing, basically, this is a normal epithelium, and then CIN1, very mild dysplasia, and then moderate dysplasia, the severe dysplasia, and in situ carcinoma, then comes invasive carcinoma. So this, you have a long period of 10 years roughly. They are very slow growing. So this is a very important point to be noted, is this is a very slowly transforming from the very mild dysplasia to invasive, microinvasive cancer to invasive cancer. It's a very slow process. So at any stage of the time, if you can pick up and treat them, then you can prevent cervical cancer. So the gist is, whenever patient has any kind of white discharge, any kind of vaginal infection, you have to subject the patient for pap smear and HPV testing, so and visual inspection, so that we can pick up early lesion and we can do some local treatment for the prevention of this HPV. See, visual inspection with acetic acid. Acetic acid application on the cervical region will cause color change, that is a white in color, and then you can pick up the suspicious lesion, and from there you can take a pap smear, from there you can take biopsy, and you can subject the patient for colposcopy if necessary. So this is 5% acetic acid, how you will make it, and these are all the various instruments which are required. It's this one and a Cusco speculum and acetic acid is more than sufficient to pick up the cervical cancer diagnosis. It doesn't require any hi-fi instruments also. This is 5% acetic acid preparation, that is glacial acetic acid 5 ml and distilled water 95 ml. All put together, it will become 100 ml solution, which can be poured over the cervical region and visually examined by a Cusco speculum and a torchlight. You can examine and identify the suspicious areas. This is the pictorial depiction, how you put acetic acid with that cotton, and then you put a Cusco speculum and a torchlight and examine. So this is a very simple method of how to identify the abnormal lesion. See, this is the squamocolumnar junction, and the thing is the squamocolumnar junction will move in. Now this is a new squamocolumnar junction. So that is how there will be metaplasia is taking place. Very simple, you can identify. This is the original squamocolumnar junction. This is a new squamocolumnar junction. This is the area of metaplasia. It's very simple. You can just look at some of few normal surfaces, then you can very easily identify the abnormal or pathological surface. And this test has to be repeated every 3 years. This is a fundamental, because and the particular documentation should be there with the woman, so that if she attends another clinician, then he should know what was the previous thing and what treatment was given. Was she given any cauterization, all those things, and then you repeat it, and what is the present status you have to follow. See, this is the, I told, visually inspected acetic acid positive lesions which appear white. See, the squamocolumnar junction is slowly shortening. See, these are all the various pictures which all this acetic acid, acetic white, we call it acetic white lesions, isn't it? These are all various levels of CINs, and this looks like malignancy. This looks like malignancy. See, this is white glistening with irregular surface. This looks like an invasive cancer. The flat white areas are generally CINs. Flat irregular areas are generally early invasive cancers. See, this is the description how the squamocolumnar junction is becoming narrow towards the internal. Prevention, some points towards prevention of cervical cancer. External genitalia hygiene should be taught to the rural population. They are, because of the lack of education and all, they are not aware. And healthy sexual habits and safe sexual habits, and avoid multiple sexual partners, and prompt treatment of vaginal infections, and vaccination at early age before beginning of the sexual life. This is going to change the, in future, is going to change the incidence of cervical cancer. Now, lastly, I'm going to discuss few things about oral cavity cancers. As you know, in India, oral cavity cancer is commonest cancer among the men, and tobacco in any form, pan, gutka, pan masala, zarda, any form will cause, is a risk factor for cancer. Alcohol along with the tobacco becomes furthermore risk for the oral cavity cancer. Sharp tooth, spices, reverse smoking, and pre-malignant conditions like leukoplakia, erythroplakia, melanoplakia. These are all having risk factors for oral cavity cancer. These are all the, what are the symptoms of oral cavity cancer? One is ulcers, red and white combination of the patches. These are, I told you about, leukoplakia, erythroplakia, and difficulty in chewing or swallowing, speech problems, loose dentition, lesions that change in color, numbness over the tongue or mouth, difficulty in moving jaw or tongue, lesions that do not heal within 2 weeks, any weight loss along with any oral cavity lesion, and any taste changes, enlarged lymph nodes in the neck, and loose teeth, lumps and swellings in the neck, and any chronic hoarseness of the voice. All these things are symptoms of oral cavity cancer. Oral cavity cancer is a group of cancers: tongue, buccal mucosa, pharynx, pharynx, and buccal mucosa, tonsils. All these we put together, we call it as a oral cavity cancers. These are all the various areas where cancers can occur in the oral cavity. So what are the pre-malignant conditions of the oral cavity? One is any white patch, that is leukoplakia. It has got risk for 4 to 5% of the malignant change. So whenever you see a leukoplakia in the oral cavity, ask the patient to change his habits like alcohol, tobacco and maintain oral hygiene and regular follow-up, then as years goes on, about say after 4 to 5 years, the risk of malignant change in leukoplekia will decrease. As such, leukoplekia has got only 5 to 10% of malignant chances of its becoming malignant. So it's not, even if you pick up the patient at leukoplekia state, you are likely to prevent cancer. And this is a non-homogeneous leukoplekia. It looks like patchy leukoplekia. This is verrucous leukoplekia. It slightly raises above the buccal mucosa. And this is the erythroplakia, as I already shown this slide. And this is submucous, oral submucous fibrosis. You can see all white thing, and patient is not able to open his mouth. This is also a risk and pre-malignant lesion for the. This is also severe. Patient is not able to open his mouth. So once again, in oral cavity, actually basically tobacco chewers and any ulcer in the oral cavity which doesn't heal more than 2 weeks, any abnormalities which I've already described, you have to be very careful. And the basic fundamental lies in ask the patient to stop smoking, stop using tobacco. In this particular year, if you make single person to stop smoking and the use of tobacco induced things like gutka and all those things, we are helping the society in preventing oral cavity cancer. You remember, ask one person each to stop smoking and stop usage of tobacco. That is my if we can do that as a doctor, we are definitely helping in decreasing oral cavity cancers. So to conclude, today I restricted myself to talk only overall view of the risk factors, some sort of screening. And to conclude, to encourage healthy lifestyle in the society, avoid tobacco abuse. Any suspicion lesion should be investigated, which helps in early detection, and encourage screening, especially in high groups, and encourage vaccination to prevent cervical cancer. I think with this, I conclude. I thank you, IMA City branch, for giving me this opportunity.
Thank you, Umakant sir, for your wonderful presentation. You could do justice to the topic. Prevention of cancer, very common cancers. Thanks a lot on behalf of IMA City branch. I would like the audience to ask questions if they have any.
Sir, this is Dr. Chandrasekhar. I would like to ask one question.
Please, sir.
Sir, in case of the mammography,
Sure.
how much amount of the radiation hazard we can say in terms of the X-ray? 30 times more radiation is something like that. Is there any such strategies there, sir? Just I would like to know.
Actually, mammography is not a very high dose radiation as everybody is thinking, or it's a wrong notion. It is a very low dose radiation, actually. Very low dose radiation, which does not carry any kind of risk of development of any cancer.
Thank you very much, sir.
Sir, good evening, sir.
Yes, sir. Good evening, sir.
Excellent topic, sir. Discussion and
Thank you, Raghu.
overall view of cancer, especially oral cavity and breast and cervical cancer, the screening methods in the and a very simplified way you have explained, sir. Umakant sir, congratulations. And
you,
one more
Raghu.
thing, sir. One question.
Hmm.
What is this reverse smoking and what is the passive smoking, sir?
Actually, the two things, Raghu. Reverse smoking is in Srikakulam areas. What they will do is the ignited one side of the cigar, they will keep it in the mouth and they will smoke. So this will cause the soft and hard palate cancers. They keep that ignited one inside and they'll smoke. That is especially in the areas of Srikakulam. That is called reverse smoking. Passive smoking, we are all, even if we are not smokers, if you sit by the side of a smoker, we do practically doing smoking only. That is called passive smoking. Even this.
So what is the
passive
incidence
See,
passive smoking?
See, it is very sorry to say, we are all passive smokers practically, because recently only there was a restriction in public smoking. Otherwise, when we were in college or public smoking was very common. So passive smoking is also good amount of risk. It is 20% risk. 20% risk of being cancer development in the lung for passive smokers also. Suppose if patient is having some genetic basis, say some chromosomal abnormality, as I told in the last 11% of unknown causes, if the patient is in that particular group, he will develop cancer much earlier than the other people. Even if he is not a smoker, he says that I am not a smoker, but I developed cancer in an early stage. That is because of two reasons: because patient has a genetic background, as well as passive smoking as a part of his lifestyle. That is unfortunate. That is the reason now governments have put a lot of statutory restrictions on the smoking in public places.
Okay,
One
sir.
more thing,
One
Raghu,
more thing, sir.
congratulations for you for becoming superintendent.
Thank you, sir. Thank you. And one more thing, sir, the hot liquids, whether it is a tea or coffee or any hot liquid, which is, will it cause any predisposing factor for the oral cancers?
Actually, it is not proven for regular tea and all, but in Chinese area where upper esophageal cancers are common, they have actually started discussing about hot liquids and the cancer incidence they have correlated. But in Indian scenario or Western world scenario, this particular thing correlation was not observed. But as you said, as you rightly pointed out, in Chinese area and in the China, initially there was a discussion regarding taking very hot liquids versus cancer, but it is not a proven one. But as you said, it was there. Initially, there was a discussion about it.
But it was not
now,
been
it is not proved.
And coming to the CA breast, sir, what is the incidence in the ductal ectasia in the sense mastitis
It
and ductal ectasia?
It is said, Raghu, it is said that any breast abnormality in a, say about 30, 40, after 45 years, any breast abnormality like lump is, even if there is any hyperplasia or atypical hyperplasia, they are all high risk for or pre-malignant conditions. Ductectasia with hyperplasia, it becomes risk. Ductectasia with atypical hyperplasia, these two are proven, but plain ductectasia is not a proven pre-malignant condition.
Okay, thank you, sir. Thank you. Thanks for clarifying my doubts. And once again, congratulations for being as one of the association member, being as a speaker. It's a really privilege to see you as a speaker.
Thank you. Thank you. It is nice discussing with you, Raghu, after a long time.
Thank you. Thank you, sir. Thank you.
Sir, good evening, sir. This is Dr. Pratyusha. I'm a physician. Sir, I would like to ask you two questions, sir. Would you share some experience regarding the relation of spices and oral cancer? And the other one is there any increase in incidence of breast cancer among younger age group females?
Smokers. You're talking about smokers and young age breast cancer?
No, oral, sir. Overall.
Overall engaged patient.
Yes, sir.
Madam, first thing is spices. Spices are known carcinogens if you take in excess amounts, especially pickled ones are known to be carcinogenic, especially stomach. In the oral cavity also, their association is weak, but it is described. And second one is young age group and cancer. There are two important components why young age group patients are developing cancers. One is chromosomal abnormalities, like genetic basis. There are certain things known as oncogenes. So presence of oncogenes and environmental factors. Like if an young patient with an oncogene inside, if he is a tobacco chewer, he will develop cancer early. When a young patient with an oncogene inside develops a HPV infection, he develops cancer early. So young age group patients with an oncogene background, if they are exposed to the carcinogens or exposed to high risk things, then they develop cancers in young age group. Nowadays, young age group patients are the incidence is increased because of this particular reason.
So are we noticing any increase in trend among young patients in India in particular
Yes,
regarding
madam.
breast cancer?
Yes, madam. But because I'm in a government sector and especially in our regular practice, we don't concentrate on research. But young patients, definitely they will have some background of BRCA1 and BRCA2 genetic background. Without that, generally young patients they don't develop
And
breast.
national anthem, if you can just start.
Yes, sir.
huh,
Yes,
that
sir.
time. Okay.
Thank you, sir.
Okay,
Thank you, Lingam.
Good evening, sir.
Good evening, sir.
Regarding this visual inspection with acetic acid,
Sir.
how often it is being done or how useful it, because it's a very useful procedure. So in a general outpatient or even in a practitioner's clinic,
Yes,
because most of the people prefer going, they will be referring for pap smears.
Yes.
So as a general, for a routine or as making it as a screening test in the general outpatient, how useful or how often it is being used?
Sir, actually, as you said, I agree with you that it is not oftenly done. But last 2 years, I was one of the trainers for this. So we are encouraging in the government sector, especially PSC and CSC levels. We have trained the doctors there, gynecologists or other interested doctors, and even including sisters, nursing staff, to do this test. Because there are one important thing is if they do pap smear, we are not getting adequate pathologists to look into the slides. So we have to get those slides to CT and then give it to pathologists, because our CSCs and PSC, they lack of pathologists to look into the slides. But whereas acetic acid, it gives a visual impression, and that particular patient can be mobilized for further test. At least you can take a biopsy. We are asking gynecologists or other our government sector staff to do a acetic acid stain and take biopsy from that, take a punch biopsy from that particular site and send it to the city. Whereas sending a pap smear slide and biopsy, so for a pap smear slide especially, if you send to city, once again patient requires another biopsy if there is a suspicious lesion. So we are asking them to take a punch biopsy and send that tissue so that we can do a histopathological examination. And it is a very useful test as far as the cervical cancer screening is test, and it is very much can be practiced in the general outpatient clinic, because it gives you hint from where you have to take pap smear. With that acidic patch, it will tells you from where you have to take a pap smear and where you have to take a punch biopsy. Punch biopsy forceps is a very cheap, it's not a very costly instrument, and you can very easily done under local anesthesia itself. So this helps in a patient to pick up a suspicious lesion as well as diagnosis itself.
Yes, sir. And one more thing, sir, you are talking about the smoking. What is the link between incidence of esophageal cancer, and the link between esophageal cancer and the relation between that and smoking, sir?
Sir, smoking causes cancers from oral cavity. It goes back to esophagus, larynx, pancreas, and including urinary bladder. Smoking is a very dangerous habit which causes cancer in so many organs, right from the oral cavity to the urinary bladder.
Yes.
Sir, there is a question from Dr. Fawad. Role of testicular self-examination in boys and men.
What?
Role of testicular self-examination in boys and men.
Yes. Actually, testicular swellings are noticed by boys only. They only come with a swelling and they examine and they say that it is increased in size. Whereas why self-breast examination is focused, because they don't do self-breast examination. It is very surprising that we notice the breast swellings which are more than 5-6 centimeters, hard in consistency, but the patient says that I have not noticed at all. That is how we observed. So many patients, they'll say that we have not examined the breast at all for when the tumor has reached up to 5 to 6 centimeters. Whereas if you look at the boys, even if the slightest change in the size, they will attend the clinician. If you are all clinicians, you might have noticed with a slight alteration in the size, they'll come to the clinician and say that there is alteration in the size from right to left, left to right. That is what they say.
Thank you, sir.
Sir, I'm Dr. Vittal Rao.
With the permission of Dr. President Wilford, can I ask him, please?
Please do.
Hello.
Please do.
Hello, sir.
Congratulations for this wonderful and simple way of keeping how to prevent and see cancer. In fact, we were with Indian Cancer Society way back 30 years back. We used to run cancer detection clinic. My suggestion is, from IMA, we should have a cancer detection, center either at IMA or at our Sai Baba clinic.
Sure, sir. I am always there for that.
That's one of my
cancer
suggestions.
screening. I am there. And my services will be there. I always attend and come, guide, and I myself do cancer screening. I am there. I'm with you, sir. Thank you very much. I am with you.
What we used to run along with Indian Cancer Society. In fact, if the branch needs, we can raise funds for that. We have some funds from Indian Cancer Society. We can pour some money in that, and we can start a cancer detection center either at Sai Baba Center or at IMA. Wilford, this should be a serious thought regarding this, because we should do something about it. See, detection of cancer.
Yes.
So the money should not be a problem. I can arrange for that.
Sure,
Thank
sir.
you, sir.
It's a nice gesture from you on the World Cancer Day, sir.
Dr. Sanjeev Singh Yadav, I would like to invite Dr. Sanjeev Singh Yadav to.
Sir.
Good evening, everyone. Good evening, President, sir.
Good evening.
Nice to hear Umakant talk. Long time I have not heard him speaking. Many of you don't know, we regularly see him speaking in surgical meets. He is one of the most dedicated persons, and the approach, you can see the practical approach he has working in a government institution, serving so many people. The approach is very practical, and he will give you a lot of guidelines. But you see, whatever said and done, our role in cancer prevention must be most important than the treatment part, because that we cannot do. Not all can do treatment, but cancer prevention, whatever best Dilip has suggested, I think this is the best time to use whatever best we can to the public. It is so nice to see a lot of women doctors doing a lot of activities around today in Telangana and other places. I congratulate Umakant for the simple and clear, lucid presentation. Umakant is a very silent person. It is very difficult to gauge him, but when you talk to him, you will understand the depth of knowledge he has. Thank you, Umakant. Thank you, President Sir, and thank you, Minaj.
Thank you, Sanjeev.
Thank you, everybody.
Hello, I'm Dr. Vittal. I want to speak.
Sir.
Please.
I say, here, in C, it has got a role regarding the oral pills to prevent pregnancy or postponement of menses. Is there any role of taking such hormonal tablets in cancer?
What, sir? I did not get you, sir. Can you please repeat?
Some girls or women who are married, they take oral pills to postpone or to prevent pregnancy. Oral pills. Has it got any role?
Yes, sir. Any hormonal replacement, including oral contraceptive pills, especially estrogen based, they have risk for malignancy. Even oral contraceptive pills should not be used for more than 5 years. Or even hormonal replacement treatment also should not be used for more than 5 years. There is a risk of about 3%, as I put it in the slide. There is a risk of 3% patients' chance of developing endometrial cancer.
I see. So hello. What about ill-fitting dentures in oral cancer?
Sir, it was described before, ill-fitting dentures can produce oral cancer by repeated trauma. Any repeated trauma in single site produce lot of inflammation, lot of cellular turnover, and because in the healing process. So in that particular area, especially dentures are used by old age people where the cell cycle mechanisms are little bit disturbed, then the chances of developing malignancy was there. It is one kind of theorem, because the old age is also one part, and repeated trauma because of ill-fitting dentures. These two factors put together probably some people have developed cancers.
Okay, sir. Very nice talk, sir. Congratulations.
Dr. Pratyusha has asked one question, sir. A relationship between food and breast cancer incidence.
Food and?
Breast cancer.
Food and breast cancer. Especially obesity. Obesity is a risk factor for cancer breast and endometrium. So any food habits which increases the fat content, or if they become obese, naturally those particular diet is the risk factor for breast cancers. Obesity itself is almost 23% risk factor for the development of cancers. That is breast and ovary, breast and endometrium.
Sir, any relation in particular with high non-veg intake and breast cancer incidence?
High non-veg intake.
Yes.
The diet which causes obesity is the risk factor for the breast cancer. The non-vegetarian issue comes to colon basically.
Okay.
Colon, because if you take non-vegetarian and avoiding fiber diet and vegetables, then it becomes a risk for developing colonic cancer.
Umakant, Sanjeev here.
Okay, sir.
I normally practice proctology, as you know.
Yeah, I know.
How much suspicion we must have for a person who comes with bleeding, hemorrhoids, and fissure? Is it necessary always to go for a sigmoidoscopy before going in for a procedure?
Actually, more than 45 years, patient first time presents with the symptoms of hemorrhoids and fissure, they have to be subjected for colonoscopy. If they are coming for the first time, suppose they do not have any previous history of symptoms of hemorrhoids, then you have to suspect proximal obstruction, and that may produce these hemorrhoid symptoms.
In spite of our dietary habits, like having a lot of food in the night, which we normally tell people to avoid, but Indian custom says night we meet together and eat. Breakfast is basically minimally zero, and lunch is a tiffin box.
Yeah. We take reverse actually. I will also follow the same. I will eat more in the night because it has become a habit for us. I'm slowly trying to change.
Okay.
Umakant, is Krishna Reddy here?
Sir, good evening, sir.
Yeah, congratulations for your best lecture. And the relation between the parity and the breast cancer, Umakant?
Sir, it is especially, sir, early menarche, late menopause,
yes,
and nulliparous, and patients who don't given breastfeeding. These are all having risk factors for malignancy. The fundamental basis for this is high level of estrogen for longer duration. Suppose patients having multiparity, those who have given breastfed, they have got less amount of high estrogen duration. That's all. Okay,
but multiparity predisposes to the cervical cancer, no?
That multiparity because of the repeated trauma, vaginal infections. That is altogether different. Multiparity will leads to cervical trauma, multiple traumas, and neglected for vaginal infection treatment. So then they develop cancer.
We have been taught early marriage and late first child is one of the reasons for breast malignancy.
Breast malignancy.
Okay.
Umakant sir.
Sir.
Umakant sir, one more doubt. This fibroadenoma and fibroadenosis, the incidence of changing of this fibroadenosis into the carcinoma, and what was the incidence? Is there any chance, in the sense whether it is with giant fibroadenoma or only just any fibroadenosis? Did you come across any such type of cancers? Because most of the people in the middle age, especially in the younger age, they are worried about this types of swellings we come across in the clinical practice.
Yeah, that's true, Raghu. That's true. Especially if there are fibroadenosis. Fibroadenosis is a very dangerous diagnosis to make, because in fibroadenosis there will be lot of cellular turnover and there will be hyperplasia taking place. If there is a hyperplasia area and hyperplasia with atypical area, they become pre-malignant lesions. Fibroadenoma as such has very less incidence of cancer transformation. As you said, giant fibromas, they have got more incidence of cancer conversion. Especially giant phylloids, they can be malignant, they can convert into malignant phylloids, and a giant fibroadenoma can convert into sarcoma of the breast, which are a different kind of cancer. We are discussing about epithelial cancers only, duct cell cancers only. Whereas these fibroadenomas, larger fibroadenomas, as you said, giant fibroadenoma, they convert into sarcomatous changes, not duct cell. Whereas fibroadenosis components, which are confined in and around ducts, and if there is hyperplasia and atypical hyperplasia, they convert into duct cell cancers. And incidence is less. You have to suspect whenever there is an increase in size of fibroadenary component, and then if there is any increased discharge, which is bloody discharge, then you have to suspect malignancy. And
so how long we can continue this medical treatment for this?
No. Whenever there is suspicion, you have to stop the medical treatment. You have to subject the patient for triple assessment. That is very important. Any suspicious lesion, even if you clinically suspect fibroadenoma, you have to subject the patient for triple assessment, clinical examination, radiological examination, and histopathological examination. True cut biopsy is mandatory. As a surgeon, you have to do true cut biopsy, not FNAC. True cut biopsy you have to do.
So that is a BRADS 3, 4, 5 should be taken into consideration.
No, I'll tell you one word. Any breast lump should be treated as malignancy unless proved otherwise. That is the dictum. Any breast lump.
Thank you for clearing my doubts. And I thank Wilfred sir and Dr. Sanjeev sir and Dilip sir and Krishna Reddy sir, all the stalwarts of the IMA. And they'll sing.
Just 1 minute, Dr. Raghu.
Thank you, sir.
I just want to congratulate Dr. Umakant Gaud for his excellent talk.
Thank you, sir.
Yeah, it is really heartening to see so very good interaction with the members. And as Dr. Dilip sir told, as IMA should take screening also in our IMA, our these patients which we are doing already. So regular screening, and also regarding vaccination, cervical vaccination, that we have to enlighten, because many of our own doctors' children also they are not taken. That's what I came to know. So this is also important. Today you enlightened with your talk, and it was a very good, appropriate talk, and I should congratulate Dr. Minhas also for choosing the right person for the right topic. And one small doubt I want to ask you. This, as you know, in our Hyderabad, we take a lot of non-veg kebabs, grill mutton, and all things burned non-veg. Is there any risk for the food, all that type of food?
Smoked food, smoked and charred food is risk for malignancy.
Thank you very much.
Dr. Umakant Gaud, sir.
Sir. Hello, sir.
Wonderful. Namaste. Wonderful talk, sir.
Thank you, sir.
Thank you. My 1 or 2 doubts are some this thing. So, is the role of prophylactic mastectomy one, and second thing is what are the diseases we are having screening in a mass screening programs? Established one.
As you said, prophylactic breast excision is done in BRCA1 and BRCA2 patients, provided patient gives a consent. It is described in the literature, and they have done in Western world. But in our country, because BRCA1 and BRCA2 incidence is very less, we are not practicing, and I have not done till now. But it is described in literature, prophylactic removal of the breast cancer in very high risk group, where BRCA1 and BRCA2 families are clustered in one particular family. And second one is mass screening is done at present in our state is for cancer, breast, that is mammography. Second is carcinoma cervix, where we are doing acetic acid examination and pap smear. These two we are doing on state government basis, and I am the person involved in training the people in primary health center and CSCs. That is why I know. And these two programs are being already started in our PS and CSCs. They are doing. But in the Western world, they are also doing colonoscopies. They are also doing screening for lung cancers. Screening for lung cancer, like sputum examination, and any doubtful cases they are doing bronchoscopies, and they are taking CT chest. But in our country, we are not doing. We are doing only 2 diseases. One is breast, second is CA cervix.
Thank you, sir.
I think Dayal, Uma, I think you should have told smoked salmon, one of the normal fishes eaten in Japan, has caused a lot of cancer of the stomach. There's a big study on that.
Yes, sir. That is why I told very instantly that smoked foods will cause cancer.
Yes, that is really, and stomach especially very dangerous.
Stomach, very dangerous. And even pickled foods, sir. Pickled foods also one of the causes for CA stomach, especially in our country.
I read one study wherein roti, whatever the black portion is there when it is burnt, that must not be eaten. Is something which has been told.
Yes, any smoked and charred things you should not eat.
Other thing is regarding the advice of taking more quantity of turmeric regularly, because turmeric is approved anti-carcinogen.
Yeah, that's what they said, but in our standard textbooks,
no, not our textbook. Even No, America has taken patent for turmeric, which actually is our product.
Yeah, that's what I also read it. But in our standard textbooks, the description of turmeric and anti-cancer things are not described with a focused things. But they have mentioned that some of the Indian foods like turmeric and all will have anti-carcinogenic effects.
It has proved now. Actual science they have proved
Dayal
it.
Singh Saab, anything in excess is dangerous. Anything in minimal quantity is also not
but if
helpful.
you are not, no, sir. I'm talking about at least adequate quantity.
Yeah, adequate
color
quantity.
के लिए नहीं, you should take adequate quantity, which will help really.
Yes. Even alcohol in limited quantity is good.
I don't agree, sir.
अब alcohol ban बोले तो मुश्किल हो जाता है ना सब, इसीलिए
आज नहीं बोल सकते.
We'll allow one more question. After that, can we conclude?
You can ask a question.
No question. I only
President,
thank
sir.
the speaker for a wonderful talk, very illustrative, very informative, and it can be also shown by the number of people attended. A fabulous gathering. Thank you, Dr. Umakant Kaur.
Thank you, sir. Thank you, sir.
Dr.
Umakant,
Sir.
and we should listen to Dr. Dilip, whatever he has suggested.
Yeah, sir. Yeah, madam. Actually, it is a nice gesture on part of Dilip sir that today is World Cancer Day and he suggested about screening from our IMA side. It's a very great suggestion. I'm there. I think I will definitely follow his guidance and I will try to be part of that cancer screening program. I will also try to get our postgraduates or whoever other people I will try to get, and we'll do the programs under his guidance or whatever the seniors, if you guide it, because in IMA, I'm a little new. So if you can guide, I am ready to do service.
Yes, Dr. Saira.
A stool focal blood test, sir.
Sairam sir,
I think you have not touched this point.
Which
want.
point, sir?
Stool focal blood test, sir. That is a screening test for colorectal cancer.
Yeah. Actually, I was concentrating only three things: breast, oral cavity, and CA cervix, sir. Because if you start talking about all the cancers, then it becomes less.
Because out of all the screening recommendations, sir, you have covered almost everything except for the colorectal cancer. That's why
colorectal cancer I not covered, sir. I'm not covered.
Yes.
Sir, good evening. Sir, actually, so you said bleeding per rectum above 45 colonoscopy is a must. What about bleeding per rectum after, rolling out any fissures and all? How much chance of CA will be there, sir? Bleeding per rectum.
Madam,
Less than 45, around 20 is like that.
If you rule out hemorrhoids and other local lesions for the bleeding from upper colon or upper region is only two things. Commonest is malignancy, second is vascular anomalies.
So for vascular anomalies, what do you suggest, sir?
Vascular anomalies, you have to do a angiogram. Most of the times in younger patients, you get AV malformations. Because
AV
AV malformation for younger patients.
Any incidents? How much will be the incidence, sir, like in India?
I don't know exactly incidents, but last 10 years we have picked up 2 patients with AV malformations and we have sent it for embolization.
More than vascular
diagnosis.
malformations,
Yes.
madam, more than vascular malformations, multiple polyposis of the colon is one of the most important factor for malignancy. But in India, it is much less compared to the European and American people, because their dietary factor does not include lot of fiber, which in our Indian diet we do have. All those spices are there, but the amount of food and the fiber we eat nowadays, it is difficult to say that because of this junk food what children are eating. But for us, till our generation, it is not a big factor. Maybe we will see more, and we have lot of redundant colon in this European people, and the length of the colon is more compared to the Indian population. That is why you see lot of this multiple polyposis. In fact, as Umakant suggested, they undergo colonoscopy once in 6 months. It is mandatory for them, but not in India as such.
And even chromosomal background is also there, sir. Chromosomal 9 abnormalities are common in familial polyposis. They come in very young individuals, actually below 10 years, like that. In 20-25 years, generally AV malformations. Below 8-10 years, generally familial polyposis.
AV malformations in just near that area, or it could be anywhere in the body also. How do you suspect?
Actually, it is not clinical suspicion. Clinical suspicion is based on the age. Below 10 years, we suspect polyposis or AV malformations. After that, suspect malignancy or AV malformations or some bleeding from polyp. Bleeding from polyp, or sometimes some benign lesion also, sometimes it bleed, sometimes lymphomas, it can bleed. So bleeding evaluation, only after evaluation you can come to arrive at a diagnosis. Clinical diagnosis straightforward is either hemorrhoids or malignancy is a straightforward diagnosis. And after that, rarer groups are AV malformations, polyposis, bleeding from a single polyp sometimes. There are different kind of presentations will be there.
So directly colonoscopy could not lead to the diagnosis, maybe for this younger age group.
Sometimes very small polyp can also bleed a lot, madam. At that time,
Yes,
angiograms will help. Very small polyp also sometimes it can bleed. Sometimes a small aneurysm, small aneurysms also can vascular malformation with aneurysm also can bleed a lot than its size actually. In fact, malignancies, they don't bleed much. Malignancies, despite their size, they don't have profuse bleeding. Whereas malformations, they bleed very profusely.
Dr. Yakender, can you kindly give your vote of thanks? Please unmute yourself. Dr. Umakant, thank you very much. Wonderful talk.
Thank you, sir. Thank you for giving me this opportunity on the cancer.
Our pleasure. Thank you. Mr. Yakender.
Yeah, thank you. I am a Hyderabad City Branch President, sir, Dr. Wilfred D'Souza, sir, for honoring this meeting. And thank you, our Secretary, sir, Dr. Dingangout, sir, and Elia, sir, Treasurer, and President-elect Dayal Singh, sir. And thank you very much to our speaker, sir, Dr. Umakant Gaud, sir, for your excellent presentation, informative talk. And special thanks to our all Dr. Dilip Banshani, sir, Dr. Sanjay Singh, sir, Mohan Gupta, sir, Gattu, sir, and all the doctors who have presented in this meeting and made it successful. Once again, thank you one and all who are present here. Thank you very much.
Thank you, Dr. Yakender.
Thank you, sir. Thank you.
Good night, everybody.
Good night. Good night, everybody. Thank you, sir. Thank you for
Good night, everyone.
Thank you.
Thank you, sir.
Good night, sir. Good night.
Good night, everybody.
Good night, everybody.
మనం కనబడతామా
కనబడతాం ఫోటో ఉంటుంది
పక్కన ఉన్నా కూడా కనబడతామా
ఇక్కడ కనబడతా
అవునా
కనపడలేదు ఇంకా కనపడలేదు అంటాను
బాగా చెప్పాడు కదా చాలా
అంటే